Hi, my name is Dorothy Grasso, School of Professional Studies. We have with us today Dr. Elaine Linung, Improving Patient Outcomes Through Culturally Aware Healthcare. This webinar will also be available to be sent to you if you need it. She will begin the talk in a few minutes. We're very happy, she's going to begin the talk now, and we're very happy to have her with us today. Welcome, Elaine Linung.
Thank you, Dorothy. It's a pleasure to be here, and I wanted to speak today about healthcare disparities and how we can improve patient outcomes by being culturally aware, both of their cultures and of ours, and how that has an impact on patient care. Okay, so here's the many faces of American melting pot, and as you can see, we are a very ethnic, beautifully diverse country, and so our objectives for this seminar are to define culture, how cultural influences can affect healthcare disparities, and what it means to be culturally aware. So we have to strive to be culturally aware healthcare provider. Why? Because we want to give the patients the best care that we can. So we have a philosophy that means that you're going to make a lifelong commitment to looking at the patient's cultural heritage, accept them as holistic, the holistic nature of health, wellness, healing, even their spirituality. All of these will have an impact on the way patients receive and get care. Many studies and articles since the 90s have stressed the need for health care as a way to reduce healthcare disparities and access to health care. And I have to tell you, I first became interested in culturally competent healthcare when I was a fairly new nurse and I was working at a large inner city hospital. And I was working in a labor and delivery unit, and we had not only a diverse patient population, but the nurses and the other staff were very ethnically diverse. And we made an effort to accommodate patient-specific birth practices, whether they wanted their family present, and I felt that we did a really nice job. And then I was floated to the postpartum mother-baby floor. And the head nurse was the nurse's nurse, starched uniform, cap, watch pinned, and she ran the unit like a drill sergeant. All of the women had to get up at 6 o'clock and shower. Everyone had to eat at a specific time. No food can be brought in for the outside. No bending of visiting hours. No fathers got to hold the babies. Now we had clients, patients, who had cultural restrictions on whether they could take a shower, whether they could wash their hair, what specific foods they needed to eat after a delivery. And I saw that they were upset and we weren't giving the best care. So that encouraged me to learn a little bit more about cultural differences. And we all know Dr. Madeline Leiniger, and she is absolutely a foremost expert on cultural care. And Dr. Leiniger really just wants us to be ongoing, to practice transcultural nursing and realize the effect that it has on patients. So how do we become competent at something that's continually changing? Don't forget, even as we're sitting here, our society is changing. There's going to be a new technological development. There are going to be more immigrants that are going to come. And as a healthcare provider, it's incumbent upon us to look at ourselves, always have a willingness to learn, be non-judgmental, and realize that this is the America of today is not the America of 50 years ago, and the America of today will not be the America of 50 years later. And we really have to change with the times. So I wanted to talk a little bit about that. Basically, you're not going to be totally culturally competent in every ethnic background. The most important thing is for you to remember good communication skills, willing to accept the care, being interested of the patient. So culture, just in case we need a definition, it's the belief, customs, arts, etc. of a particular society, group, place, or time. And that's the short one. The longer one that I wanted to just talk about a little bit is that we all come with a culture. Healthcare providers, the culture that we were raised in, the culture of our profession, the culture of the organization that we work for. So we have to look at our own culture, and we have to make sure that we are remembering that we are there for the patient and being very aware of their culture. Subcultures. Subcultures are a group that has beliefs and behaviors that are very different from mainstream society. One of the largest subcultures that we have are the lesbian, gay, bisexual, transgender, and some people include I and Q, which are intersex and questioning. They represent, it depends on what study you're reading, percentage of the population. However, we are going to be taking care of patients who are either self-identifying or who are afraid to identify as one of the genders, and we need as a different gender or preferring different sex partners. And it's not just enough to ask if they have sex with men, women, or both. It's important to look at the person, develop a relationship. I myself had an experience when I was working at a health center, and a young woman came in for a women's health exam asking for birth control pills. Well, I did the exam and I couldn't visualize the cervix or feel a uterus, so I asked our GYN expert, and she came in, and the first thing she said after the exam was, "Have you had any surgery?" And then the young woman said that she was transgendered. And we did ask her why she wanted birth control pills, and she said it made her feel like a real woman. So it's very, very important to show compassion, respect, and be open. Our unique American spirit and American culture is a result of all the immigrant groups that have come here. This is what makes us uniquely American. And we have an identity as Americans in the rest of the world for being open, friendly, exciting, changeable. Our society is not closed. And as different cultures come in, their practices are integrated into society. We learn from the new immigrants. They learn from us. So throughout New York City, we used to be called a melting pot because of all the immigrants that came on the Lower East Side. But as I'll tell you later, I still think we're more like a patchwork quilt, with each square contributing to a really beautiful, exciting looking quilt. Now, New York City is one of the most linguistically diverse cities in the world, where the English does remain the most spoken language. And in the outer boroughs, such as Flushing, Sunset Park, and Corona, we have patients and clients that really do not speak English as a first language. And we need to have healthcare providers that are aware of that and will work in those communities. This was the latest slide that I pulled from the New York City website, and it talks about the 10 largest immigrants in New York City. And I'm sure that you're aware of most of them. And recently, we are receiving a big influx of immigrants to New York City from the Middle East, and we're trying to absorb them into our culture. And it's very important to remember that while many of them are Muslims, there are other religions, which include Hindus, Sikhs, and Buddhists. So it's, again, important that we are aware of this, don't make assumptions, and provide good care for our patients. So there are other ethnic groups. They aren't new immigrants, but they have very close-knit communities. And again, if you're called upon or you're caring for one of the patients, you need to be aware of some of the factors that you might need to know to give them optimal care. And just one example I want to give is the Orthodox Jewish community. They may prefer, women prefer female providers, men may be very uncomfortable with women. So cultural influences. We have established ethnic groups, and this is definitely influencing the community's views on health, poverty, welfare, and crime. And we've got to get the public agencies involved and to do interventions, to get out there in the community, to talk about what's available, and to help them get the services they need. Why are minorities a vulnerable population? Well, any group that comes in, we seem to have a fear of something that's different. And so they're also stigmatized. They're afraid of stigmatization. They have language barriers. They may look a little different. They may have an ethnic dress. Some of them may be illegal, and so that makes them afraid to go for health care. So they need social networks and a good community support system. When they do get health care, they often have incomplete screenings, and partly there's a lack of linguistic competence. We don't have translators for all of the different cultures, and we need to be a little more flexible, open, and encourage people to be able to translate. Now, access to care has improved dramatically with the Affordable Care Act, but we're still pretty behind in that, and we need to make health care for all a priority. Some of the healthcare disparities in our minorities include African American women whose breast cancer is diagnosed later, and even when it's diagnosed, they have some differences in the care. This leads to poorer outcomes and a higher incidence of mortality. In the African American and Hispanic communities, we have poorly managed hypertension, diabetes type 2 is prevalent, and we have higher rates and more poorly controlled asthma. So they have asthma rates and hospitalization because they tend not to have a primary care provider and use the ER as their provider. So we need to get more primary care, more clinics into the community. Again, we talked about comorbidities in the Hispanic population, and coronary artery disease, it's also very large in that population, and also women are a minority as well, and everyone thinks that, or many people think, that the largest killer of breast cancer, women is breast cancer, but it's actually coronary artery disease. Women are underdiagnosed. And again, I talked about how African American women are just are diagnosed later, and even if you adjust for income and education and stages of cancer, the outcomes are poorer. So we know that minority women are more likely to have chronic conditions, and men are more likely to have heart disease. And we can talk about, you can see some of this. So there's cultural or religious barriers that prevent health screenings, mammographies and colonoscopies. People are afraid of it, people don't understand it, and we need to get out there and explain to them why they need these screenings, how it's going to help. Certain ethnic groups may resist efforts to stop or reduce smoking or alcohol abuse. There's also stigmas related to depression, mental illness, fear of getting HIV. There's a huge distrust of healthcare professionals, and we need to be able to have them trust healthcare professionals. We need to recognize that immigration status can be a barrier and a fear, and we need to help them obtain insurance. We can look at the chronic disease slide by race and ethnicity, but you can look at that later, I think. And so healthcare providers need to understand the patient's cultural background and what prevents them from following directions or doing what they're asked. Some of it's a lack of understanding. Some of it's that their healthcare beliefs are different, and yet we're so quick to label patients non-compliant. And it's money. Okay. Factors in influence adherence. We need to adherence. We need to get a partnership going between the patient and provider. We have to give trust and respect. And again, as I spoke about, they have to understand the regimen and what's expected of them. In some cultures, you'll have patients agreeing with you, even though they don't understand you because they don't want to upset you. And yet they go home and they're not really sure what they have to do, or because of their cultural expectations or background, they may feel they only have to take their blood pressure medicine on a day they're not feeling well. And again, we have to know their attitudes towards illness, death, and end-of-life measures, and they may not fit with our thoughts on that subject. So in this challenging healthcare environment, how can we do this and provide patient-centered care? Well, we have to ask, who are we? How do you self-identify? Look at your own impact that your culture has had. And again, as I spoke about before, what's the culture of your profession? How has that impacted you? How is the institution you work at affecting what care is given to the patients? So we have to acknowledge we're all products of our culture, and that the most important thing is that the patients come first. In order to do that, you've got to examine your biases and know your strengths. In the community, we want to know the community, who our population is, because that's how we can tailor our care. We have to find out what their attitudes are, what their beliefs are, and how that has an impact. We all know we need the promotion of preventative care practices, and some groups don't often come for preventative care, and again, that leads back to lack of knowledge, lack of confidence in the system, and again, they may also believe in practicing their own home remedies. So again, we talked about this, patients' ethnic or minority groups, and it's very important when a patient comes in from a different ethnic or minority group to know who the family's decision maker is. And you have to establish a trust with the patient and family. Many patients will not make a decision at that point unless they discuss the decision with the head of the family. And that may seem a little bit different for from our culture, because we talk about the patient has the right to make the decision, we talk about HIPAA, and we have to understand that yes, those are important, but for that patient, it's more important to go home and discuss it with the decision maker and the family because they feel that it's a collaborative decision. So what do we have to remember? Caring, communication, and collaboration. And that is the way to decrease the healthcare disparities, increase patients coming in for services, and feeling that they're safe. And they know when you're sincere and when you're respectful. They know when you're compassionate. And you have to be able to compromise. It's sometimes you have to use the harm reduction method, because you're not going to get someone to give up smoking on the first try. You're not going to get them to reduce their alcohol level from 10 drinks to nothing. And if you really push your agenda, you might not get them to come back, and then they're going to have consequences because they're not going to get the care they need. And so we need to remember we're all part of the human family. Despite the differences, we have shared values. We want our family to be healthy. We want our children to do well. So we need to, they may just have a different expression of the values, but we need to respect them and understand them. RNs, we spend a lot of time with the patients. So we really have a lot of power. And so it's expected and it's incumbent upon us to provide culturally sensitive and aware care, to be aware at all times what the patients need. And we spend the most time with the patients at the bedside in the home. And we rank for the 14th straight year as the most honest and ethical profession. And I think we should be proud of that. And that's why I know that with just simple reminders and a little bit of thought, we're going to actually provide the care, the culturally aware and culturally respectful care for our patients. So here we are again with the awareness. And again, we need to look at the differences, how they impact the patient's perception and willing to accept care. I wanted to talk about some of the traditional practices that many of the cultural groups have that we may not be familiar with or comfortable with or totally believe in. However, some of them are very helpful, and others can be a little bit not helpful, and some are outright harmful. However, we can't be dismissive of the practices, because if we are, we're going to lose those patients. And they do have ancient forms of healing, herbal remedies. We all know acupuncture can work. There are some that are a little scary if they want to do a prayer circle around the patient. And we may not be familiar with that, but it is very helpful if they want to call in one of their spiritual healers to pray over the patient or even do a ceremony, and that might be a little odd for us. However, that is bringing comfort to the patient and comfort to the family, and anything that does that actually promotes wellness. So we need to be flexible. We need to take a look at that, and we need not to simply say to the patient, oh no, we don't believe that here. Some Hispanics will go to curanderas, other Asian populations will go to traditional, other patients will go to holistic healers before they come to you. They also have different birth and death rituals and family health traditions. And one of the familial health traditions are foods that they might eat, home remedy practices before they'll see a provider. Birth rituals may differ from some of ours. They may not speak the baby's name. They may not give a name till the 8th day. Death rituals, they may want to stay in the room with the patient for quite a long time. Or even as it's going on, they may refuse any kind of care except for just supportive care at that time, because they believe that that's the way that a person needs to be at the end of their life. They need to be let go. So we have areas of intersection, and that's where the healthcare community comes into the cultural community, and where we need to look at them as we're a little bit different. And so there are all kinds of areas of intersection, things that we might not be totally aware of. Some of those approaches would be good communication, look at the gender, look at your manner and how you approach the patient and the family. Remember, some ethnic groups are very modest. They don't want to be touched in a certain way. They want to be covered. They may have a very different diet. And one thing that would be nice if we were more flexible on is providing a variety of foods that comfort the patients. However, that goes back to, again, the institutional and culture and, I guess, money. But some of the patients have sacred objects that they wear all the time: amulets, red string, religious medals. When I was working on the Lower East Side, I had a mother come in and she had a red string tied around the baby's abdomen, and on that red string was a quarter, and it was to keep the belly button in. I had no problem with it as long as the patient did not get a fungal infection underneath, wasn't hurting anybody, and that's where you have to accept their healthcare beliefs, and it made her trust me more as a provider because I wasn't judging her for having a slightly different belief. Spiritual beliefs, many patients believe that if they pray over the patient, or you know, that priests that want to come in, rabbis, and that they need to be able to bring those in and for us to respect their spiritual beliefs. Again, we talked about family structure, who's the decision maker, but we need to make time for our patients, and we're always rushing. And sometimes it's not that we don't want to be competent or caring or sensitive, but we're very pressured for time. And we don't realize that a patient who has some linguistic differences or who comes from a different culture may not be quite used to everyone rushing around them. They may be used to a healthcare provider sitting and talking to them. It may be they need you on a more personal level. And so that will affect the outcome and whether they're going to choose to come for care. This was the student experience that we were talking about when we were talking about culture, and I found it so very moving. And I'm not going to read the whole thing to you, but my student had an injury to her leg, and apparently when they got ill, home remedies were the first choices. And I didn't change her words because it really sounded so moving when I read it in her own words. And she had a problem when she peeled the scab off, there was obviously an infection underneath. So her dad said, let's try this home remedy, and it was a spider. And he roasted it, and then he put the ash in the wound. However, that didn't work. Then he moved on to tobacco. And by that time, she had a big hole in her leg, and the wound was red and smelling. And he knew he had to take her to the clinic. Now, in their village, they were very afraid of the clinic. But he knew that his child needed something more. So he braved the norms of the village to bring her in for care. And when she got there, everyone at the clinic was very supportive. They praised him for bringing her. They understood he was the decision maker. And she got antibiotics, and she got well. And when she came to America, she wanted to be a nurse because she realized that people from her community who were here needed to know the benefits of both types of medicine. And she talked a little bit about African culture, which is different health issues, and that they want to be a good patient and not give problems. So they might not tell you about their pain. And she talked about the ideal of health, which is tied to their roots. They are still learning about health and healthcare and how it's different in America. So she said, you know, they're learning to eat and speak differently, but now they have to learn to go to the doctors for regular checkups, and they need to speak up about their issues without looking like they're being bad patients. And they feel that healthcare workers need to explain more why it's important for them to see the doctor and do more education. So she's very proud of being a nurse and proud that she can help our culture. So we need to know if they're from a different culture. Are we asking the right questions? We have to realize some patients are not going to answer if you say they're in pain because their culture tells them to be good and not cause a problem, and they respect you. Some won't make eye contact with you, and that's not necessarily that they're afraid of you or not respectful, but it's not respectful actually to make direct eye contact with someone who they consider knowledgeable, important. So a pain scale, sometimes when you go over to the bedside and ask the patient, tell me where your pain is, they're really not going to tell you. So how do we assess this patient and provide relief and comfort? And that is a question, and I don't think I'm always perfect at it either. But maybe you want to ask instead of, do they have pain? Maybe good to let them know, or the family member know, whoever is the decision maker, that you can give them relief measures for pain. And it's not something that should make them feel bad about themselves, but this is one of the benefits and one of the things that is going to help them actually get well when they're less focused on the pain and their body can use that energy for healing. Patient-centered care, we talk about it a lot, and it's customized to the physical, emotional, spiritual care needs and beliefs. And we really want equitable care, and we believe in safe, timely, and effective care. And again, some of the barriers to that are the institutional cultures. But we have to remember, especially as nurses, who are we? We're patient advocates. Should we advocate the modern healthcare system, which is simply, unfortunately, money-driven and rushing? Or is it important for us to look back at the values that we profess to have and promote all of the good that we can do for our patients? So what can we do about that with our students? Well, the curriculum needs to include education about cultural awareness and use some more examples, perhaps patient simulators, perhaps making sure that students are taking histories and spending more time with patients of different cultures in the hospital. And it's important for all healthcare professionals. We talk about interprofessional education. We need to talk about intercultural education. So you need to be aware that in different settings, we're practicing all over the place, nursing homes, hospitals, and outpatient settings, and we need to promote this. Again, examine your own values. Be aware of the culture of the profession you belong to. And remember, again, we're there for the patients, no matter what setting we work in and no matter what setting the patient is in. Some of the little mnemonics that might help you to remember on how to interact more with a patient of a different culture, and some of them I like and some of them I don't. But this was one of them that was called ethnic, and it was explanation, treatment, healers, negotiate, intervention, and collaboration. I did actually show this slide to my students, and some of my students said, Professor, that sounds like bias. Or if the patient doesn't want a provider of a different culture, is that bias? And I said, well, we all have the right to choose, or at least to try to choose our provider, and we're all a little bit biased. And it's a good topic for a conversation. But what we're trying to say is that all of us need to be able to provide the same, care for the patient. Patients can, if you say, I want a woman provider, ask for a woman provider. And we need to think why they're asking for someone of their own culture. Is it because trust hasn't been built up? And there's a certain amount of bias that exists in all of us. It's our job to break down the barriers, look at the biases, and still react as a professional and provide good care. So this study was done in '82, and they talked about learn as a mnemonic, and it's very similar. You have to listen, you have to explain, acknowledge, make recommendations, and negotiate. And this is very important because if you don't acknowledge their concerns, they're not going to follow what you are telling them. So you need to make a recommendation, and if they don't really want to do that, again, we have to negotiate. What can you do? What will be acceptable? And that's important, and it's always two steps, a step forward and two steps back. And it's just very important to remember that as long as you can keep them engaged and keep them coming into the system, eventually we're going to make changes and we're going to be able to give them the care that they need. It's a slow process, and sometimes as nurses or healthcare professionals, we want something to be completed, and it's not going to be completed at the end of that interaction always. So we need to be aware of the patient's attitudes. We need to make our organization that we work for aware of their influences on the patient's attitudes. And we have to develop a plan of care to help clinicians improve access to quality care. And again, be the change you want to see in the world. Gandhi spoke about how action changes things. And it might be just something small, but as long as we're making an effort and speaking to the patients, we can be effective. One of the things is nurses can be on committees in the hospital, and we need to get more of a seat at the table. We need to ask to be there. Our voices need to be heard. We are one of the largest healthcare professions. We are large in numbers, and again, the patients respect us. We need to use our clout and be a little more political and get involved and be there for the patients, because we can do it and we want to do it. Again, we speak of the melting pot, and again, I look at our nation as a patchwork quilt where the whole is greater than the sum of its parts. We are a nation of immigrants. None of us were here originally, and we have brought many, many strengths to America. And that's our strength, all of the things that the immigrants bring to us. Our culture grows, it develops, it changes. We learn more things. Everyone learns more things. We're a much richer society, I believe, than a totally homogenous society where everyone is the same. America is a good place to be, and it's obvious because people still keep wanting to come here despite all of the problems we have. So we're committing to be culturally aware, sensitive, and accept people for who they are, where they are, and all of their beliefs and spirituality. And it's necessary for us to do that so we can provide safe, effective, and timely health care. So you have to commit to self-awareness so that you can begin the process. Because if you don't look at yourself, you're not going to be able to overcome some of your own issues and then see the patients and be respectful of their needs. So our patients, families, and communities deserve nothing less. As a country and a people and a nation, we are committed to providing accessible and affordable care. It should be a priority to each and every individual. We're a rich country. We need cradle to grave, absolutely affordable, respectful health care that will promote health, because we don't want to just be a disease treating model. We want to be a nation that is promoting health and supporting the health of all of our citizens, because no matter how they got here, they're Americans. So we want to encourage and support minority students. We want them to enter the healthcare professions. We need more scholarships. We need mentoring. And if we can do all of that, we're going to improve the outcomes and the results and the healthcare disparities. Okay, for more information, you can reach me at elining@citytech.cuny.edu. You can also get information from up here at the School of Professional Studies. And I really want to thank the School of Professional Studies for having me come here and speak on a subject that's very dear to my heart, because I know that we can do it, and we will do it because we are nurses and we can do anything. And we will be providing our patients and our communities with the care they need so that there's optimal level of wellness for everyone. Thank you again. So while I'm waiting for questions, I did want to tell a story about a negative interaction that I had encountered. A patient was telling me that when he first came to this country and his English was not that fluent, he got a PPD test for a job, and it came out largely positive, so they sent him for a chest x-ray. And there was a spot on the x-ray. He was trying to explain to them that that had been there for many years, and he shouldn't have got the he shouldn't have got the PPD because he did have a BCG vaccine. However, he didn't have a previous x-ray to compare it to, and the doctor at the hospital felt that he needed to be admitted to be evaluated for tuberculosis. Now, the patient had no signs and symptoms, no hemoptysis, no cough, no fever, no night sweats, but he felt that he had no choice. He was pushed into being admitted, and he was put in the positive pressure room. He was terrified. He asked for a doctor who spoke his language, and the doctor himself who was caring for him and the nurses just didn't get that for the patient. And again, this was over 10 years ago, so that could have been part of the issue. But you also have to look at the doctor's issue, because he was feeling, from what I heard, that he was a good doctor and that the patient wasn't trusting him. So he was a bit angry. And now the nurses were a bit angry that he kept complaining about being in the positive pressure room and wanting out. And so they viewed him as combative and not cooperative, and it created some more problems. So he was discharged, and he did not have TB. But he wouldn't go anywhere near doctors and hospitals for a good long time after that. So it did have an impact. But again, there were some positive stories and there were some negative ones, and that's always going to be the case. But that one stuck with me because I was thinking that it is terrifying to be in a new country, not to understand the language, and then to feel you're imprisoned, in a room waiting for the verdict whether they're going to release you or not. So if anybody would like to even share a story, I would be very happy to hear it.
I was working, this is Dorothy Grasso from the School of Professional Studies. I was working yesterday assessing a clinical group in community nursing, and one of their projects was wonderful. They are dealing with a Hispanic population. Some of them are bilingual, many of them don't speak English, and what they did is they created their end of their 7-week presentation with PowerPoint slides. And many times the students will do the PowerPoints in English, and they were going to, what they ended up doing this time is they did them in English, but they also did the exact same slide in Spanish, and a student spent hours doing this. And then they also have another group of Chinese-speaking population in another clinic, so they did the Chinese version as well. So they had the English and the Chinese and the English and the Spanish, like 2 separate slides, but it was a wonderful presentation, and this is what we need to include more in the communities. We need to make sure that they're understanding what we're saying. Many of them get lost in what our point is and what we're trying to say. But if you can get somebody to interpret what you're saying on the slides in Spanish or Chinese or Russian or whatever your community happens to be, it's wonderful, because the presentation was beautiful. It happened at exactly the same time, and it wasn't somebody just speaking over the slides. It actually was written out in their language. And the one thing I learned yesterday, I guess I'm a little ignorant, but the Chinese, I know there are different dialects, but they said the written Chinese language is all the same. So it was wonderful. So they wrote it all out, and it went very well, and the patients loved it, and they created handouts in all the different languages. And this is just from students that are in the Nursing 303 community course. And then I also have students in the capstone course, which is Nursing 499 at the end, and they're also working on that as well. So this is how we can make changes in this world, is by being aware that people need cultural awareness from the ground up. We love to educate, we love to teach people, and we only speak English maybe. So then you get an interpreter, get somebody to help you, make sure your handouts are appropriate. There's a lot of organizations out there that have a lot of different languages for their patient ed materials. So that was just something else that I thought I'd throw in there. Are there any more questions? Okay, so feel free to contact us on the information given on the slide, nursing@sps.cuny.edu, and the telephone number is 646-344-7271, and that's for CUNY School of Professional Studies, and we do RN to BSN in nursing. If you have any questions for Dr. Linung, it's elinung@citytech.cuny.edu. Thank you for coming to the presentation. We really appreciate it, and I hope you enjoyed it. Thank you.